him tell you any other background he would like to and explain his tie, and we'll go from there.
Thank you, Dr. Latassi. Good morning. My name is Jim Brandt, and as Dr. Latassi said, I've been a family physician since well into last century. I grew up in Oklahoma, so Route 66, which is what my tie is if you're at Okie, then it has some significance to you in terms of Oklahoma history. And I've actually been to a couple of places on my tie. So today we will talk, my assignment was to discuss and review endocrine gland imaging, those orders or those tests that are available to you as a provider, things that you can order. A lot of this test is a bit of redundancy, but that's how I learn, is repetition. And so much of this lecture is pathophysiology and a review of those things that you should either be in the course of learning or have learned based on organ systems such as the thyroids or the adrenals or gonads, that endocrine system, so to speak. So I am very comfortable with you asking questions. If I confuse you, if I'm not clear, you just raise your hand, stop, and I'll make sure that what I said was correct and that everybody's on the same page. Additionally, at the end of this lecture is my email address. If you have a question, then send that to me, and I'll be happy to answer it. But what I need, if you send it to me, is your group email, so that when you send it to me, I have a way to answer you back as well as everybody in the class. It's always my intent to strip your name off of the email so that the class gets the notice that here was the question posed by one of the students, here's my answer, so that you all get the question, you all get my response. It's not my intent to identify you in that. If I did, it's because I failed to strip your name off. But that's how I will answer questions. If I can't get a group email back, then I will just reply to you and say, please send me the group email so I can answer your question. So, probably the thyroid gland, which I think is the second gland that we'll talk about, is the gland that you as a generalist will most commonly be involved with evaluating, examining, and ordering some of the tests that we'll talk about. You'll see what those tests look like, the things that you order, so that when you read through the report that you get because you ordered the test, you'll have an idea of what the radiologist is talking about. So that the thyroid is the gland that you will probably most frequently order testing on. The other three glands are less likely for you to study, but you may actually order a parathyroid hormone. You may actually do an evaluation, endocrine imaging exam of the parathyroids. Usually by the time you're looking at adrenal glands or the pituitary, one, you have your supervising physician involved, and they may have actually been referred on to someone else in a more narrow specialty to help order the testing. But as we are all involved in electronic medical records, if you refer that patient to a subspecialist who gets the report, it will probably come to you as well. And so you will have the opportunity to read about the study that they may have ordered. Any questions so far? So we'll get started. All right, so So we'll start with the pituitary gland. The pituitary is a gland that, as you know, is rather small, but packs a powerful punch. It has two portions to it, an anterior lobe and a posterior lobe. The posterior lobe generally is never a problem. It hardly ever develops an adenoma or a tumor or a hormone secreting tumor. It's also that portion of the pituitary that's intimately involved in labor and delivery and in milk production and milk letdown in nursing or breastfeeding moms. The anterior pituitary, if something's going to go awry in the gland, the anterior lobe is the lobe that's most likely going to be involved. And that when it starts over-functioning or under-functioning, then you really, when it starts to under-function, you really get no problems in the head when it quits producing the hormone. What you get is the results of those end organs not being stimulated to produce their hormone. So in the setup for hormone production and function of a gland's not going to do anything unless it's told to do something. Either it's stimulated with a trophic hormone that stimulates it to do its job and it produces that hormone, or there's something wrong with the gland producing the trophic hormone, which then ceases production of the trophic hormone. The end organ does not get any stimulation, it starts to shrink, its production decreases, and then the patient has symptoms: amenorrhea, anovulation, inability to develop mature sperm for reproduction, or a decrease in androgen hormones, or decrease in the thyroid hormone, for example. So as the process goes on, the anterior pituitary will either overproduce a trophic hormone or underproduce, depending on the process. So what you may find is a patient develops milk production in a 28-year-old who's had a child before and now has suddenly developed milk production from both breasts and has not been pregnant in 5 years and is not currently pregnant. And so that should make you start to think backwards. If you're getting milk here, why is the milk happening? What's making the milk production? And thus what's causing your pituitary to secrete hormone that might stimulate milk production. So once you find the symptom or finding on exam, your job is to start thinking backwards as to where is the etiology. Either it's a primary failure of the pituitary in this case, and so end organs don't produce their hormone, or it's secondary, that something happened to the pituitary that makes it not produce. Now, that may sound a bit confusing, but if you evaluate the pituitary because it's not producing its hormones, you start from that assumption that it's not producing any of its trophic hormones, and you evaluate the patient and you can't find any reason for that loss of production, then that's a primary failure. Secondary failures occur when something is actually going on in the gland or around the gland that causes it to quit functioning. That process can be an infiltrative process where things like lymphomas or sarcoidosis, where other substances get deposited within the pituitary matrix and in between the cells, and that buildup of either lymphatic tissue or sarcoid tissue results, protein tissues, get in and are deposited and crowd out the normal gland, and by pressure cause the gland to quit functioning. They don't knock it off. So when you decide, aha, this is the pituitary, then your question is it a primary or a secondary process? And this slide gives you a list of those hormones that are produced in the anterior and posterior lobes of the pituitary, and thus you can see that organs such as breast with milk production or milk letdown, thyroid dysfunction, or gonadal dysfunction are the results of either overproduction for the pituitary or underproduction. It's a lot of talk about one slide. It won't be this long, I promise. Okay? So any questions before we go on? You understand my symbols, male and female? Okay? So, we're talking about the pituitary. You know where it is. Where does it sit? Exactly. So here you can see this, the slide on the left with the red square, that's setting right, that is the sella turcica. If you have sliced that patient, the top of their brain off, like on one of the Hannibal Lecter movies, and set the brain aside and look down in it, that you're looking down at the sella turcica. In the old days, when Dr. Latassi, well, maybe before her, but certainly when I was there, we didn't have, CTs were just coming out, MRIs weren't invented, no PET scans existed. So if I had a patient who said, I have a headache, I can't get rid of it, I've had some change in my vision, and I have milk production, and I'm 47, and I had a hysterectomy 10 years ago. What's going on? When you put all that together, you wonder, is this a pituitary tumor? And so the only thing that we had as practitioners was our physical exam skills, our history-taking skills, and plain x-rays. And that's what you see on the right. That is a sagittal view, or cross-sectional. This is a lateral. It's called a lateral skull. That's what we did. We checked, we did a lateral film looking for this area that's labeled 4. That's the sella turcica. And what would happen is you would get this plain x-ray to look at, and you would also get what's called a coned down view, where the next film is focused specifically on that area. You get coned down views when you do lumbosacral spine films. They will also do a coned down view at the L5S1 junction, because when the beam is out here, it distorts the actual anatomical appearance of L5 on S1. So we do cone down views here, you would get a cone down view on the skull, and you would look to see if this area in here was relatively small and and all of the bone was continuous. All that rim of bone was continuous and not disturbed at all. So you are right. The answer is the sella turcica, and there's actually a movie called Sella Turcica. And imagine, but it's about a Turkish soldier who returns from World War II. That's all I know. And the list of actors was no one I knew. So this is a coned down view. This is what I was talking about. So you would look to make sure that all of this plate or table was intact, and it was continuous with the actual sella turcica that made this almost complete circle in which the infundibulum and the anterior and posterior section of the gland sit. So if that patient that I discussed came in with that those symptoms, and you were worried about a tumor, and you took a cone down view, what you might see is that this plate of bone here has been pushed down and seems not as solid of bone as it should be. And the bottom portion is relatively intact, but what you lose is you lose a really distinct continuation of that saddle on around. And that's because there is infiltration of proteinaceous material, if this were a sarcoid, for example, or the anterior gland that produces oxytocin those cells are either multiplying and the gland gets bigger, or those cells are enlarging because they're overactive and the gland gets bigger. And that pressure over time will eat away and cause necrosis of the sella turcica. So this would have been your confirmation based on your exam and history findings that probably this patient has a pituitary adenoma. And those were difficult to treat for the most part. So that's what you would see. You can still get these films, but if you have the suspicion there's an adenoma, most of the time we're going to go to an MRI study at this point in time. So you have an MRI that shows that the gland itself, this is normal, and so this patient's MRI for headache would show you a normal pituitary, and if you took a lateral film, it should look like that. But when the patient has either a failure or an overproduction, then you end up with an MRI that would suggest an enlargement, that this is not a nice smooth gland, it's starting to grow, it seems irregular, and there's some added tissue down here that's probably pushing down on the sella turcica and causing it to resorb and disrupt that nice, frank, bony edge. So, my example was a patient who had an adenoma that was overproducing a tumor. One of the things, a gland can either overproduce, underproduce, or be normal. And if it underproduces, your job is to figure out why. So you find you have a patient who's having hypothyroid symptoms because there's no TSH or no thyrotropic hormone being produced by the pituitary. They come in with symptoms of hypothyroidism, and you eventually track it back to the pituitary. You wonder, why is the gland not functioning normally? So you would order an MRI. You might get something that looks like this, or recorded in the write-up from the radiologist like this, and now you have to decide, is this a patient who's, this is probably either idiopathic and not the other two, because this MRI is a study of a pituitary gland that's bigger than normal. And so that's usually an infiltrative process like a lymphoma or Hodgkin's disease or sarcoidosis. That tissue, either proteinaceous tissue from sarcoid or actual tumor metastatic disease from the marrow or from the nodes, has infiltrated the pituitary, and that metastatic tumor is growing, making it a big tumor on the MRI, but actually crowding out the normal hormone-producing cells of the pituitary. Sheehan syndrome is a patient who will never have Sheehan syndrome. Very simple. Who? Men. That's right. So Sheehan's is that patient who has either a pan-hypopituitarism or hypothyroidism, something, some version of pituitary insufficiency, because they have had almost always, this is, well, by definition, this is related to hypotension caused by postpartum hemorrhage. And those, think about how small this gland is, and so think about how much smaller those vessels are that feed the arterial side. So it takes very, very little sustained drop in pressure to not perfuse that gland that can set it up for either dying off or loss of some of the cells that produce the hormones that we're talking about. Pituitary apoplexy is kind of an interesting term that we don't know. It just means we're apoplectic, we're speechless, we don't know why this happened, but tag, you're it, your pituitary has quit. It could have been from a head injury, you fell off the tractor, hit your head, thought you just had your bell rung, and it actually was enough to torque and twist the vasculature and cause the pituitary not to function anymore. Or you had a fever, you had a high enough fever in which the pituitary itself was damaged and leaves you with either panhypopituitarism or just one or two of the hormones not being produced. So that's the pituitary. If you can understand and recall what it makes, you can work your way in a stepwise fashion to the answer to the question your patient brings you that relates to an endocrine function. And the pituitary is the classic example of one gland makes a trophic hormone that stimulates another gland to make its hormone that then gives you the end result, such as thyroid hormone production. MRI is now what we order, and in our system down the street, I could order this study and I could actually pull it up once it's been read and signed off, then it becomes available for me to look at. So I look at these studies much more than I used to 10 years ago, where I didn't have copies, I didn't go to a radiology suite to look at these studies. Now they're online, and it's actually made it easier for me to follow and understand it, and better at reading the studies. So now we'll go to the thyroid gland. Most of my, I think I've identified where I have pulled these either pictures or graphs and things off. Some of the X-ray films will show our patients that were teaching files from the university, and their patients are de-identified, and there's really no copyright or anything to them. But this is one that I pulled out of a text that you can see to the left there. So what happens is, now if you just focus on the thyroid gland is difficult to examine in some patients, impossible in others, and so you should take the opportunity in every patient to practice feeling of the thyroid. It's only by feeling lots and lots and lots of them that you get more comfortable with deciding, was that really a lump or a bump that I felt or not? The thyroid gland is this butterfly-looking gland, and we'll see that exemplified in some films here shortly. It produces 3 hormones, and it does that only because the pituitary tells it to. So once the thyroid receives the signal from the pituitary, from the thyrotrophic hormone, it then produces any and all of these 3 versions. The T3 is the hormone that actually works and helps regulate your bowel activity, your resting heart rate, your general sense of well-being, weight loss, weight gain, that sort of thing. T4 is the major hormone produced, minimal activity, kind of functions as a warehouse that when the body in times of stress needs more T3, it takes too long for the gland to make T3, So your body inherently knows to convert T4 to T3, and then it can supply the added T3 that's necessary for whatever the stressful situation is. A burn, a fever, an infection of some sort, post-op from gallbladder removal, wisdom teeth pulled out, stress from a bad haircut. So reverse T3 is not active, but can move back and forth from T3, reverse T3 to T3. So it's kind of another storehouse as well. And when you're thinking that a thyroid is the problem, the cause of the patient's complaint, we'll generally get only a TSH to start with. So your patient comes in with these symptoms of, it's winter and I'm wearing shorts, I'm too hot, I've lost some weight, everybody's hair is falling out, so I disregard hair thinning and that sort of thing. I've never seen the skin hyperpigmentation. You really have to kind of go a long ways before your melanocytes have had enough time to be stimulated to increase your skin color. So a patient who comes in and they're hot, they've had some weight loss, their hair is thinning, and you do your exam, and certainly they have, maybe their resting heart rate in a 35-year-old is 96 or 110, so they may have some tachycardia when you examine. You may be able to pull out hair as you examine their scalp. If this has gone long enough, they may develop the exophthalmos aspect of hyperthyroidism, where there is fat and protein deposit behind the globes that push the eyes out. So you get the Marty Feldman effect, where their eyes are out and actually they fall out in the politically incorrect times. Those were individuals who were in the sideshows and the traveling circus and that sort of thing that could pop their eyes in and out. It's because they almost certainly had hyperthyroidism, and they had this end result where the proptosis, where their eyes were pushed forward. So as you feel the patient's neck, you may feel a general bigger thyroid than you might expect. You might find one side that seems bigger than the other. Look at them. Sometimes you can see it. And I ask patients, if you wear a collar, or your shirt's tighter, is it, you feel more choked when you put your tie on anymore? You notice something different about your neck when you look in the mirror. Sometimes patients have noticed it too, and they're focused on something else today, and you just happen to notice their neck doesn't quite look right. So you need to feel that thyroid, get them to do the swallowing maneuver, see if you can feel any nodules sliding up and down behind your fingertips. And so, this is pretty much the 1920s, 1930s time frame of a woman who had a goiter. And that's pretty remarkable. It's hard to not stare at that when you meet the lady for the first time. And so she probably had some hypothyroidism because she had an infiltrative process that was crowding out the thyroid and made the goiter. She could have, but is able to maintain or produce enough to kind of maintain her weight and her activity, but probably she doesn't feel well in general and is overall fatigued from hypothyroid aspect of a goiter. Sometimes the goiter, though, is from hyperthyroidism. This lady's not hyperthyroid. If all that gland was making thyroid, she wouldn't have sat still for the picture. She would have been all over the place from just too much energy. Obviously, this is a post-mortem section, but you can see the thyroid cartilage here. You can see this thyroid is firm in appearance. It is somewhat smooth, but this is really a diffuse goiter in which both lobes and the isthmus are enlarged. So you go to the opposite. You're either cold all the time when everybody else is hot. You may have some weight gain. You may have depression. Thyroid disease is always something to consider when your patient has concerns about being depressed or any worsening depression. When you think about patients having carpal tunnel syndrome, you also need to think about whether that's a reflection of hypothyroidism. So as you examine and take a history about wrist pain or numbness or paresthesias in extremities, think about, could this be hypothyroidism? And even though they're talking about carpal tunnel symptoms, you remind them that you need to feel their neck to make sure their thyroid is intact, and you may want to check out the TSH on these patients. Physically, they may have hair loss. Also, they may have some thickening of the skin. They may have drier skin. There may be a pitch change in their voice. And in men, that's not a big deal. In women, it may be noticeable, so men may not comment on it as a symptom when you query them. And the voice pitch may be a permanent change that may not resolve it once you resolve the primary disease. But we talk about facial edema and that may be present, and then slow, deep tendon reflex. That's what DTR means. I've never seen that. I guess I would know it if I saw it, but I've never seen it in a patient that I've examined in 30 plus years. So now you decide that the thyroid is maybe the problem with either hyperthyroidism or hypothyroidism. So you do your exam. You need to document your exam. It's normal or it's not. Doesn't matter whether you're right or wrong. You just need to document it. Tell the consultant what you felt. You're going to do some TSH, T3, or some TSH testing. You may do T3 and T4 as well. But the easiest, the cheapest, the fastest thing to order is an ultrasound. Whether you feel anything in the gland or not, if the patient has symptoms that you suspect may be thyroid disease, it is very reasonable to order that ultrasound, regardless of what you feel. And even if their TSH is normal, and why would that happen? Why would the TSH be normal, but you eventually get an ultrasound that's not normal? Think about what happens if your TSH is high, and I put you on levothyroxine at 0.1 milligram or 100 micrograms. If I start you on thyroid medicine, how am I going to know that you are on the right dose? So I check it, follow up TSH. How much longer do I need? How long do I need to wait? A day, 6 months, 2 weeks.
6 to 8 weeks.
6 to 8 weeks, 6 to 10 weeks, at least 6 weeks. So what may have happened is she's had a couple of weeks of hypothyroid symptoms. You do your exam. You're not very good at a thyroid exam. You're not sure. You check a TSH. It's normal, but you still decide to do an ultrasound because you may be in that 6 or 10 week window where she's now having symptoms. Her TSH has dropped, has gone from being in the middle of the road to working its way up. In our lab, anything over about 4.5 is abnormal. And so she may be in that 6 or 10 week window where she's still normal, and she's managed to come and see you, and you've managed to order her serum testing at a time where she still has a TSH. If you waited 2 or 3 weeks to order it, and this is hypothyroidism, that TSH would eventually be abnormal. But you don't need to wait until her TSH is abnormal. If you have a clinical suspicion, then you order the ultrasound. Easy done, doesn't hurt, and what you get is this. If you were with the ultrasound tech, you would get this sort of thing. This is the trachea, this white aspect, and then this is the thyroid gland, that traditional butterfly shape with 2 lobes and an isthmus. So ultrasound is very, very good at telling you that bump that you feel is either a solid nodule or a cystic structure. They will feel the same to you. Perhaps an ENT surgeon might be able to, or an endocrinologist say, well, I can tell the difference. Okay, you win, that's fine. I'm still getting an ultrasound. And so I get an ultrasound and I either get this study that's normal, or I get one that shows a nodule or a cyst. That's the only thing you're gonna see. You're gonna see normal tissue, nodule, or a cyst. Now, sometimes they will say it's a complex cyst, where it's not just this traditional water balloon, that actually has some stuff in it. It has tissue-appearing things, either floating or attached to one edge of this balloon on the inside. So there may be a complex cyst, but generally it's going to be normal gland, solid nodule, or a cyst. Now, also, what you might find are all 3. A thyroid gland doesn't just necessarily make one cyst or one nodule. You may have a multinodular border where the ultrasound says there's 2 nodules in the right lobe, 3 nodules in the left. Here are their measurements. Don't worry so much about the measurements, just worry about that they found a nodule versus a cyst. Because if there's a cyst, then that's that has a little bit higher probability of being a tumor than a nodule. Just by the fact that there are so many benign nodules that the cystic structure that may contain cancer, since they're so infrequent, that makes them more likely to have a cancer. And as we'll see in a moment, nodules then, so you've got this in your mind, you've got normal tissue, you have a cyst, or you have a nodule. And a nodule can either be hot or cold. If it's hot, it's overactive. If it's cold, it's underactive. And we'll see an example of that here shortly. The other thing your ultrasound can do is it will actually, a good ultrasound technologist may be able to demonstrate the parathyroids, or at least the top 2, and maybe not the bottom 2. That's not what they're there for. That's not why they're doing the ultrasound, but you may get that as a oh, by the way, we saw the parathyroids and they look fine. So an ultrasound can see them, but we generally don't do an ultrasound on parathyroids. Yes, ma'am?
Just from the standpoint of ordering, do you just put down thyroid ultrasound?
Yes.
Well, they want other information, like here was the TSH, here's, we found this on physical finding.
The radiologist who actually has to sign the official reading will never fault you for giving them more info. They want info. If your question is fracture in a foot, pain for 5 days after running a marathon, pain in the lateral side of the foot, absolutely, they want that info. Same thing with ultrasounds, MRIs. You tell them symptoms of hypothyroidism, TSH pending or TSH 12, And leave it at that. Or you could, or if you felt something suspicious, nodule in the right thyroid. So giving them that info is absolutely helpful for them to know what you're looking for. Because otherwise, it's kind of a Karnak magician, you know, the wizard. He's just kind of, what do you want? They ordered this test, and so now I'm covering all these bases because I don't know why they ordered it, but here's all your options of what I see on this study. And if you can help pinpoint what you're looking for, they're going to better be able to answer your clinical question.
Do you have to tie it to a diagnostic code?
Yes, you do. So you can, if you feel something, you can give them a diagnosis of thyroid nodule and tie that nodule to ordering the ultrasound. Or hypothyroidism based on your symptoms, and you tie that to the ultrasound. Yes, that's going to be, coding is going to be part of your life. So at least you're growing up only in ICD-10. And so by the time you're out of practice, your electronic system should have all that settled. But insurance company's not going to approve a study without a diagnosis that would support the need for that study. All right. So that's what a normal thyroid ultrasound is going to look like. If you felt a nodule and the ultrasound said there's a cyst or there's a nodule there, then what you would generally order as a subsequent test, based on the ultrasound findings, is a thyroid scan. And there are two options, and you want to be sure you order the correct one. And so now, as Dr. Ratassi pointed out, now you have your patients come in, you've done your exam, you've done your TSH is high, you've ordered an ultrasound that says there's a cyst. So now you've got a thyroid cyst as a diagnosis that you can tie to ordering the first of these two studies. And actually, in my example, let's make this a thyroid nodule. So you find a thyroid nodule on the ultrasound, you give them a diagnosis of thyroid nodule. Now you're going to order an iodine-123. Iodine-123 is radioactive, but really not worth worrying about. Patients get this this radioactive marker, they ingest it, they come back, and they sit in front of a gamma-type camera, and this kind of image is what develops. So this is not just a single snap like an X-ray is. Generally, this takes some time to then hold still and let the radioactivity from the gland hit the plate or the film, and then it gets developed into this sort of finding. So this is a normal scan. Notice it looks very much like this normal ultrasound, kind of butterfly shaped. That little round button in the bottom is a radioactive marker, and it's about the size of a penny or a dime, and they set it right in your sternal notch. And that lets the radiologist see that this thyroid gland is uniform and normal in its anatomy, because some patients will have some accessory tissue that extends from one of the lobes down into the mediastinum, and that is normal tissue, and so it would also take up this radioactivity. And what would happen in a patient with an extension is you'd have this kind of appearance just streaming on down into the mediastinum. And so you'd see it running in what it looks like it would run into that marker, and so the radiologist would come back and say, normal right and left thyroid, normal isthmus, then a mediastinal extension from right thyroid gland. And that becomes important if in fact there is some tumor of the thyroid. You're not going to just be looking at the butterfly area, you're going to have to somehow evaluate that extension that goes into the mediastinum. This is another, this is really what gets plated out for the radiologist to look at. And this is a normal study as well. This is a scan that is reassuring and shows no nodularity, no cystic structures. And in the upper left corner is the normal thyroid gland taken straight on, fairly close up. The upper right-hand corner is the scan taken from farther back. You can kind of visualize the skull and the chin going upward. All of the tissues will absorb a little bit of this radioactivity, but here's your chin pointed up kind of, so that the patient is like this and the scan is further out. So now it not only gets this part of the face, it also shows you that marker that we talked about earlier, sitting down here in the thyroid notch. And you could almost make out perhaps there may be a little bit of extra thyroid tissue extending down. But this is labeled as a normal scan. These two views are just different, are views where instead of the patient being in front of the camera like this, such as in the upper left corner, the patient turns their head to where one lobe or the other is more directly on the camera, so that the radiologist can see that in fact that gland does have normal, uniform, diffuse distribution of the iodine-123, because we'll see in a bit where a cystic structure or a hot nodule will light up, and sometimes it's enough that it won't show straight on. You will only find to do the your head turns. So this is an example with an artist's rendering similar to that other. You see, here's the sweep from the shoulder up the neck. Here's the chin, our mentum sticking down. This is a iodine-123 scan taken because you either felt a nodule, patient had hypothyroid symptoms, something that would suggest their thyroid is overactive. Remember, a thyroid can be diffusely overactive if the pituitary makes too much TRH and stimulates the whole gland, or you can have a couple of cells that decide to produce on their own and not be responsive to TRH levels from the pituitary. They just make thyroid hormone. That's their job, they're going to do it, and they're not going to mind anybody. So these are kind of like adolescents. And so you can see with all this scatter that the tissues all will take up iodine-123, but because that collection of tissue is so active, it sucks up the vast majority of the 123 and thus highlights it, and it tells you this patient has a nodule in the left lobe of the thyroid. So now you're left with another decision to make. What do you do with that? Well, let me see. The third button down says most cancers are cold. So that's talking about nodules. So most cancers are cold nodules. This is a hot nodule because it's overactive. So it's less likely to be a cancer. And most endocrinologists and most ear, nose, and throat guys and most pathologists will say, leave that alone, leave it where it is. If we need to, we can do a fine needle aspiration. That's what the FNA stands for. And in our clinic, that used to be done by the pathologist. They would come over and in our clinic, do a fine needle aspiration, 1 or 2 biopsies, stick a needle in that nodule, and then in 2 or 3 hours, we'd have an answer that it's suspicious for a cancer or not. But most of these hot nodules are just overactive tissue and not a cancer. And most of us are comfortable saying, leave it alone if you can tolerate it. If it's barely overactive, we may give you some medicine to try to suppress the symptoms so you have less tremor, less nausea, less frequent bowel habits. But if it's overactive and you can't tolerate that overactivity, then we can surgically take it out. It's a risky surgery. Or we can kill it. And we kill it by burning it with more radioactive iodine, an isotope that's iodine-131. So the 123 you can give the patient, and there's no special precautions. But iodine-131 can only be given to individuals who can control their bladder. You don't want incontinent patients leaking urine in the bed. On the sheets you can wash and it'll be okay. The mattress is going to remain radioactive for a while. So you don't want kids on it. You don't want those individuals who can't control their bladder function to have this radioactivity because it comes out in the urine and can contaminate wherever it lands. So, and I have a patient that way. I have a dementia patient, mild dementia, lives in a nursing home, but has to wear adult diapers. So we are doing nothing but monitoring it. We're not, because she would have radioactivity all over the place, and that's not a good thing. But if you're young or you're old and need this and you're continent, then we can treat you with iodine-131. Very simple, easy, painless. And what happens is your hyperthyroidism now becomes euthyroid if the mathematician figuring out how much iodine-131 we need is spot on. What's happened to my patients is that somebody gets paid a lot of money, I think, to take height and weight and body fat and all of this and figure out you need half a bucket of 131. And the next patient needs 2/3 of the bucket. So they go through their calculation, they decide what your dose is, they give it to you. Then that patient comes to see me in 6 weeks, and what do? I check the TSH. So, and I ask them about their symptoms, I actually talk to them, get a history, how you feeling? Oh, I have constipation, my hair is falling out, I'm gaining 10 pounds. So, what's happened, probably, is the guy who did the calculations was a little overzealous or added some correction factor that blew up his formula. And so her iodine-131 dose was too much. And it killed the nodule. There's no hot nodule anymore. It also killed off enough of the rest of her gland that she can't produce enough with what gland is left. So what's your answer to that? Thyroid replacement hormone. Every day for the rest of your life. Not too big a deal, no. But when things work perfectly, she would have got the dose that killed off enough of the nodule that she was now more euthyroid and not need to have medicine. Over time, she might become hypothyroidism, but women primarily, but men as well, as you get older, there's a group of people whose thyroid just doesn't function, regardless of what you've done. So if your calculation's great, iodine-131 works perfect. all but one of my patients have become hypothyroid when they've had a hot nodule treated with iodine-131. Those 4 or 5 women have become hypothyroid because it knocked off too much of their thyroid. But their hot nodules gone. We had one patient who didn't get enough. So she got a dose. She came back. Her TSH is still out low, and she's still not gaining weight, and her hair's falling out, and she's jittery all the time. And so I check her TSH, it's low, and she goes and gets another dose of iodine-131. And so then what happens? She joins the rest of my patients, and she's hypothyroid and takes a thyroid pill every day. So, the really cool thing is that you can get the symptoms, feel the nodule, look at it on an ultrasound and see a solid nodule. So you do this study and you get this kind of a result back, and so you send the patient, you continue to manage the patient, get them sent on, they get iodine-131, you follow them and you see them in follow-up, and you get to see how, if you were able to feel a nodule, that would have shrunk, her symptoms are better, she's fine, and you fixed her with the input from these kinds of imaging.
I have a question.
Yes.
Is iodine-123 only diagnostic?
My understanding is it's only diagnostic.
Okay. So when you order a scan, do you need to specify the isotope? or
Yes. A very good point. Because if I don't, then the scheduling people will call me. So you tell them that you have a nodule, left thyroid nodule on ultrasound, iodine-123 study.
Would you ever order a 131 as a diagnostic?
I would not, and I don't think you should.
Okay.
Clearly, you would not do these on women who are pregnant, but for the most part, anybody else is fair game. Yes, ma'am?
Can you get a definitive diagnosis on the scan for a cyst, or will you need a follow-up FNA to be more definitive on that?
You would have to have a fine needle aspiration. Because the cyst part, the fluid is not what you want. You want pieces of the rim, that rim that is thyroid tissue producing this fluid. And so what we're looking for is your ability to get a piece of that balloon to look at. Okay. So this is an ultrasound where that nodule that you felt is, can be, sorry, this is not an ultrasound. This is a 123 scan that shows you this bump that you felt, that you ultrasounded and found to be a nodule. Now you've done the iodine-123, and you can see that there's this defect here, and that's the actual cold nodule, because it didn't take up iodine like this one. Even though that's would technically be 123, or this is a 123 scan, where it took it up as a hot nodule. This area is a defect where that solid structure on ultrasound is now a cold nodule because it didn't take up the iodine-123. So this nodule should be biopsied or surgically removed. They just take out, because thyroids are so bloody, they would almost always just take out that whole lobe rather than trying to carve out the thyroid, not the cold nodule. They just take the whole lobe out, because you can function well and normally with just one lobe of the thyroid. So most of the time, if you feel something, it's going to be benign. If the ultrasound turns out to be a cyst, that has some increased risk of cancer and should be biopsied. And if it's if it turns out to be a solid nodule,